All right, so what are we talking about today? Let's get to the actual crux of it, and that's our ECG. So as usual, we always start off with just our history. So we've got an 86-year-old woman, complains of generalized weakness. We always remember we start with our axis, rhythm, we analyze the rate, and then we analyze each zone. And then we try and come up to an answer and try and figure out what we're going to do. All right. So 86-year-old woman complains of generalized weakness. Scary looking ECG if you are a bit unsure. So the best way when you've got these scary ECGs is just to unpack them bit by bit. So let's go to a big picture. Come sit. All right, so we've just got one participant here. All right. So 1 second. Right. So the first thing we need to start with is the axis. So anybody want to just give me a quick answer as to what the axis is? Very good, left axis, left axis deviation. All right. So let's have a look at the actual ECG itself, and then you guys can tell me what do you think this could be. Because let's start first with our P waves. All right, let's take it bit by bit. All right. So let's look at the actual morphology of our P waves over here. What do you guys notice?
Well, it's quite a prolonged PR interval.
We're getting to the PR interval, but I'm talking about just the P wave morphology itself. Can you see it's not consistent?
Yeah.
I'm not sure if you can make that out. Right. So remember the first half of your P wave refers to your right atrium. Second half of the P wave to your left atrium. All right. So that's how you need to look at it. All right. So in certain ones you can see the right atrium's not functioning 100%. The left atrium always seems to be working, and then we've got the right atrium coming back, then we've got right and left. So that's just a question of morphology and how morphology works, all right? But anyway, we're getting to atrium morphology later in the year, but I just wanted to show you guys. Now, Hedi, you were talking about the PR interval.
Yeah.
So what's happening in that PR interval?
Well, it's sort of lengthening each time.
Very good. So it starts off, it's quite long already. I mean, it's nearly 2 big blocks long. And then it goes to, again, just over that. And then it goes to, again, just about over that. And then it kind of drops 1 over here, you know? So the question
like a
is...
Wenkebach almost.
Sorry?
It's just like a Wenkebach almost.
Right. So very good. What else is a Wenkebach known as?
It's type 2 heart block.
Wenkebach is also not type 2.
Isn't
type
it?
1.
Wait.
Type 1.
Whoever's microphone is on is like next level happening here.
Let me just have a look and see. Okay, so we got, do I repeat that delight? Who is that? Not you. Okay, I'm just going to mute everybody for now.
Okay.
All right. Are you a Zoom user?
Me? No,
Yeah.
I Duval Getty's iPhone, I think.
All right, no problem. So I just muted some over there. All right. So I think as you need to answer, then you just switch off your mic or switch on your mic and just talk. All right. So we have got a rhythm disturbance, that's for sure. All right. So we've got these odd morphology P waves that are slowly but surely sort of lengthening, and then our QRS complexes, are they narrowish, wideish?
Narrow.
Yeah, that's very good. So Hedi, it's just me and you talking at the moment. Huh? Everybody else just keeping quiet. And
cool, I'll have my personal touch.
All right. So, but anyway, let's not stress too much about it right now. Okay. What we've got is that we've got a type of a block. All right. Yeah. So let's just say for now we've got let's just say we can't decide. We've got a 2nd degree heart block. All right. It might be Mobitz type 1. It might be Mobitz type 2, because we've got this lengthening PR interval. And then all of a sudden we get this drop. All right. We get this drop that's going on. All right. So we can see immediately that there is something going on. We've got narrowish QRS complex, a borderline narrow. Okay. We can't say a QR complex follows every P, because we can see that we've got dropped complexes, all right? And we can see that it's definitely irregular, okay? So that's for sure. So let's look through some other things and see what we can see. So our rate here, rate is determined by the 2 closest QRS complexes to one another. So generally they're quite regular, otherwise in between. So we can say the rate is about 1, 2, 3, 4, 5, close to 60, maybe just a bit over 60. So it's not really a Brady at the moment. Okay. And then we look at each zone. So we need to look at our inferior zone. And, we just need to see. You guys are welcome. I just put on this because there was nobody here initially. Sorry, I've just got 1 or 2 people in the room. So just so that they could hear me a bit better. So that's why I put this on. Okay. So, yeah. So what do we see in zone 2? I mean, inferior zone, I'm saying zone 2. This is not next steps. What do we notice? Any abnormalities that you pick up, you can talk about, or anything that looks odd.
Yeah, so your S waves, QRs,
you've got very deep S waves. You've got this very odd sort of looking T waves over there. They may not even be T waves. It's what we call a strain pattern. So there's a little bit that's going on over there, right? But again, we're just looking for, is this also due to ischemia and things like that? So that's the inferior zone. Leads 2, 3, AVF, right? If we come to the septum, V1 and V2, what do we notice?
Yeah, some inverted T waves and ST depression.
Yeah, inverted T waves. But more importantly, what's this look like?
Oh, like a bundle branch block.
Very good. And because it's V1 over V2, it's a right or left bundle branch block?
It's William Morris. It's right bundle branch.
Right bundle branch block. Very good. So you can go with William Morris, or you can remember that V1 and V2 look at the right ventricle, all right? Whichever is easier for you. Okay. All right. So I like I say, Ashim, everybody else, no answers. Okay, no, that's fine. If you're feeling shy to talk, you can chat as well. It's not a problem. All right. So we can see that we've got a right bundle branch block so far. We know we've got a conduction abnormality or a rhythm abnormality. And just for the people who came in late, this is an 86-year-old patient with generalized weakness. That's all. That's all that she's presenting. All right. So let's look at the anterior part of the heart, where you can see V3 and V4. What do we notice?
It's ST depression again, and also inverted T waves.
It looks there's a bit of an ST depression going on over there. A bit of a T wave inversion. Very good. Similar pattern over here.
Yeah.
Yeah, it does look like a similar pattern over there. Unfortunately, we don't have much. I mean, we've just got one thing to go on in V5 and V6, but what can we see there as well?
Yeah, the rhythm abnormality again.
Yeah,
this high takeoff.
Yeah, you can see that rhythm abnormality, that's for sure. So you can see this V5, V6, and things like that. Can you see my laser pointer? Are you guys on Zoom? Or is it not showing up? Oh, you can see it, all right. Okay, so you can see again this little, conduction abnormality with a bit of an ST depression over there. And then we go to the other part of the lateral side, which is the high lateral, 1 and AVL. What do we notice over there?
So like a third S wave.
Yeah, basically. So just some sort of conduction abnormality, not normal T waves. So considering we've got this many ST depressions, we see in AVR, again, we've got this, I wouldn't call this an ST elevation, not like what we had the last time, but it's pretty close. But this is actually, part of that whole right bundle branch block thing that's going on now in AVR, all right? But do you think ischemia may have been involved in this? It's a possibility, isn't it?
Yeah.
Possibility. Because right bundle branch blocks all by themselves don't normally mean much. You know, anybody can have a right bundle branch block. I can do an ECG for 10 people now, and 8 people may have right bundle branch blocks. It doesn't mean that they're sick. It just means that they've got right bundle branch blocks. You know, it's an incidental finding, but you have to look at it in the context of the patient as well. So you've got an 86-year-old, she's quite elderly. It would be nice to know if she's diabetic, whether the heart is insensate and things like that. But I mean, she came in for weakness, you know. Unfortunately, we don't have much more information than that. But considering that we've got all of these ST depressions on this side, we've got a right bundle branch block, we can kind of assume that there's a good chance that this may be due to ischemia or electrolyte abnormalities, one of the two, all right, at that age, okay. The other thing I just want to look at is just the R wave progression, all right. Now, it's a bit difficult when you've got, all of these bundle branch blocks and things like that, but we can still make some assumptions, all right. So let's look at it in an easy way. V4, V5, V6, lead 1, and AVL. Which side of the heart are they looking at? Right or left?
Say that again.
V4, V5, V6, leads 1 and AVL. Which side of the heart are they looking at?
The left.
Left side of the heart. What do we notice about their R waves? Quite tall, eh?
Mm.
All right. And what do we
So like
notice?
hypertrophy.
And lead 3 and lead AVF, which side of the heart do they look at?
Inferior.
Inferior. So what can we assume is happening? Because they're dipping in the other way quite badly as well. So what can we assume about the left heart? I mean, we're not going into exact specifics. We're just talking about in general. We'll get to the criteria later on when we become a bit more comfortable with ECGs. But what can we say is happening to that left heart? If there's a lot of electricity coming towards it, and we can see it's mirrored on the other side, has it become larger? Is it the same size? Is it smaller?
Larger.
Larger. So that's called left ventricular hypertrophy. Very good. Okay. So that's a simple way to look at it. Ideally, you just look at these ones here, and then you can pick it up from there. But I just wanted to show you throughout. So what's the biggest debate we have? The biggest debate we have is what type of rhythm do we have here? Because that's the biggest abnormality that we have. And then once we know what rhythm we've got, then we can decide what's causing it. You know, we can always look at that after that because there's multiple reasons. You know, our TROP-Ts may come back negative, our cardiac enzymes. What if our electrolytes come back abnormal? So that's the first thing that we need to do. So the ECG is guiding us. So let's have a look and see what we have here. So this is a Mobitz Type 1. All right. Now, don't worry, this is not the end of it. I just wanted to show you. So it's a sinus rhythm with second degree AV, block type 1, Mobitz type 1, Benker-Bach. All right. The rate is about 50. Sorry, I miscalculated that. Left ventricular hypertrophy and a right bundle branch block that we saw. All right. So Mobitz type 1 is characterized by regular P waves. The rate here is about 65 beats per minute with progressive prolongation of the PR interval until a P wave fails to conduct to the ventricle. Usually there is also progressive shortening of the RR interval until the P wave is not conducted. All right. Left ventricular hypertrophy is diagnosed on this ECG based on the R wave amplitude in lead AVL being greater than 11, left axis due to LVH. So let's go back to this one and have a look at those criteria. So you've got these P waves that are slowly elongating, right? But the one thing I want you to notice is that this is a narrow complex QRS, all right? The reason why I mentioned this, just like Hedi, as you are talking, it becomes what you call it, a bit confusing sometimes for people. So I thought, let's look at both of them today and see what do we see. So let's compare it to this one here, all right? So we've got an 85-year-old woman, presents after some syncopal episode, still reports lightheadedness. All right, let's analyze this one quickly. So let's go first through the axis. We've got what axis?
Also left axis.
Also left-sided axis. Very good. Okay. Sorry, just want. Do you guys want to hear what they are saying? Can I take it off my earphones? Would it be easier for you? Oh, okay. No, that's fine. All right. So they don't want to hear you. All right. Okay. So it's a left-sided axis. All right. The rate is quite slow. The rate is quite slow. So the rate that we're looking at is 1, 2, 3, 4, 5, 6, 7, 8, 9. So it's just above 30. So it's a severe brady that this patient has got. All right. So let's look at the rhythm now. So first, let's look at P wave morphology. How do the P waves themselves look? Some are hidden here. No, the P waves themselves actually don't look too bad. You could argue one or two are a bit thinner and higher than the others, but otherwise they're generally okay. And what about the PR interval? What do you notice about that? Staying quite regular, isn't it? It's not generally changing. It's not elongating and things like that. But what's happening? What are we missing in some of these areas? QRS complex, all right. And tell me about our QRS complexes themselves. Are they narrow or wide? A little bit wide-ish, isn't it? Okay. And they, of course, they're irregular completely, all right. Let's look at each zone then. So we've got the inferior zone. What do we notice in leads 2, 3, and AVF? See a little Q wave there, isn't it? That's quite typical of a Q wave. All right. What do we see on the septum, V1 and V2? Freddy, are you there? Did you disappear? Normally you've been talking. No, he's disappeared. Okay. Just admit people back in. Sorry. Okay. So, like I was saying, in V1 and V2, what do we notice? Q waves as well, isn't it? V3, V4, which is the anterior part of the heart. What do we see? Just this. There's like these QRS complexes that are a bit wider. Again, like a strain pattern, a left ventricular, possibly a fascicular block, things like that. And then V5 and V6, we also notice this type of a strain pattern that's going on. And the same thing with lead 1 and AVL. So I just wanted to point out something again here. Now we'll get to this a bit later. So we said it's a left axis deviation, isn't it? Am I right? And what did we notice the last time? We had on all our lateral leads 1, AVL, which way were they pointing?
Downwards.
Upwards. Yeah, they were pointing upwards because they expect the left heart to be quite big, isn't it? Because we've got this deep lead 3. So something doesn't make sense here, agreed? Shouldn't all of these also be pointing up? Yeah.
Right.
So what I'm saying is that just be careful before you suddenly decide to cover and say everything is left ventricular hypertrophy. Just have a look and see. Now, this actually is a fascicular block, but we're not going to get into that too much right now. I'm going to teach you guys that in a few weeks' time, all right? If we start with that now, everybody's going to fall asleep because we haven't even covered a lot of the basics yet, all right? But just to show you, be careful before you declare something on an ECG, all right? So let's look at our 2 rhythm strips that we had, all right? So in the first one, we had a PR interval that was slowly lengthening, agreed? And then eventually we'd have a QRS drop. In the first one, we had thinnish QRS complex. In this one, we've got slightly wideish QRS complexes. And then in this one here, we see what you would call it, that it's quite irregular, even compared to the other one. The other one was regular, but then irregular. This one here is just irregular. So this one that we are looking at now is what you call Mobitz Type 2.
2 to 1 drop.
All right, this is a Mobitz Type 2 pattern. Okay. Now, this one here confuses everybody, especially when they go for the ACLS courses. All of a sudden, everybody just assumes that ACLS is trying to fail them because they ask which one is Mobitz Type 1 and Mobitz Type 2, but it's actually quite easy once you get the hang of it, all right? And we're going to learn the differences just now. So this is a sinus brady. The reason why they say sinus brady is because your atriums are functioning normally, all right? Even though we've sometimes I've taught guys and but anyway, it's a sinus brady. It's true. The second degree AV block type 2, Mobitz type 2. The rate is very low, 50. As we said, there is a left bundle branch block, but we'll get into that at some point. All right. So Mobitz type 2 AV conduction is characterized by intermittent non-conducted P waves, similar to Mobitz type 1. However, in contrast to Mobitz 1, Mobitz 2 is associated with constant PR intervals in those beats that are conducted. Mobitz 2 is usually associated with a bundle branch block. So when you have a bundle branch block, do you expect your QRS complexes to be narrow or wide?
Wide.
Wide, because there's a bundle branch block. There's something that's preventing conduction. So your QRS complexes must become longer as compared to Mobitz type 1. So let's look at the two side by side. So we've got Mobitz type 1 and we've got Mobitz type 2. So we're comparing our criteria, all right? And that's the easiest way to remember which one is which. So in both of them, do they have P waves? Yes, they have P waves. The atriums are functioning in both, all right? The PR interval is probably one of the biggest differentiators between them. So in Mobitz type 1, the PR interval becomes progressively elongated. So you have shorter, longer, and then suddenly it drops a beat. In the Mobitz type 2, PR interval remains constant, generally prolonged, even though in this one that we had, it wasn't prolonged, but generally it is prolonged until you have a beat that is missed, okay? Your QRS complexes are generally narrow in Mobitz type 1, but in Mobitz type 2, they tend to be a bit wider, generally, all right? You can have narrow complex, Mobitz type 2, but that's not, I don't want to get into that now. It's quite a complex thing. But just so that you know, Mobitz Type 1, QRS narrow, Mobitz Type 2, QRS wide. Anybody doing ACLS this year? Planning to? No courses available this year, eh? All right. But what I can tell you is that when you go for these courses, there are two favorite ECGs to put up and confuse you are Mobitz Type 1 and Mobitz Type 2. And they're so easy to differentiate once you know the differences. All right, especially these two. Once you have a PR that becomes elongated, narrow QRS complexes compared to a constant PR, generally wide, you can differentiate them in no time. All right. QRS does not follow every P, even in the other one, QRS does not follow every P. Mobitz Type 1 is generally what we call regular, irregular, because your beats tend to get missed at the same time. So you have normal PR, lengthens, 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 let's say 4 times, and then drops, and then starts again. Lengthens, 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 and then drops. So you have a 4 and a miss. So you have this regular, irregular heartbeat. But Mobitz Type 2 generally is irregular, irregular. All right, remember they taught us this in medical school, regular, irregular, irregular, irregular. So this is generally irregular, irregular, but can be regular, irregular as well, although that's less common. All right, so when you find irregular, irregular, it's more likely to be a Mobitz Type 2. Okay, all right, very good. So let's look at the two of them again. Now it should be a lot easier to see the differences. All right, so we see our P waves. All right. We also notice the morphology of the P waves in this particular one, but we're not too worried about that. So we see a PR interval that's lengthening, all right? We see a PR interval that's remaining constant, all right? We see narrow QRS complexes compared to, well, it doesn't reflect so much there. Maybe here you can see it more, but generally wider QRS complexes, all right? And here we see regular, irregular, although technically this one here is also irregular, irregular, but if you really look at it, it's regular, irregular, and this one here is completely irregular. Can you mix the two of them up ever again? Shouldn't. All right. You may get confused, but if you can remember Mobitz Type 1, the PR interval slowly lengthens and then drops, and Mobitz Type 2, PR interval remains constant. Mobitz Type 1 tends to be narrow complex, and this one here tends to be wide complex. Even if you can remember those two criteria alone, you'll never mix up Mobitz Type 1 and Mobitz Type 2. Okay. All right. Kelly, have you got that?
Thanks.
Good. All right. Okay. So how do we treat these patients? It's like how we did the last time. It's a management for bradycardia, right? It depends on whether our patient is stable or unstable, all right? That is basically what tells us what's going on. As you can see, all of the possible causes, all right? So a heart block, we're talking about ischemia, but these are others: hypoxia, acidosis, hypokalemia, hypothermia, toxins, trauma can all cause it. But the most important thing is it stable or unstable? All right. So if it's stable, then what do? You try and set up your drugs and get everything going that way. If it's unstable, you start with pacing. All right. So the drugs haven't changed. The drugs are just the same: atropine, dopamine, or adrenaline. All right. Can anybody remember what we talked about with those two last week? Atropine. All right. Generally will help with the narrow complex bradycardia. So do you expect to use it for Mobitz Type 1 or Mobitz Type 2?
Type 1.
Mobitz Type 1, it would be a much better one, And adrenaline, which is what we have so these two are the two that we have readily available. We still use the same, 1 amp, 200 mils of crystalloid at 5 mils per hour, can be increased to 10 mils per hour, but it's generally of more help in wide complex. So you'd expect it to be of more use in Mobitz Type 2. Okay, got it, understand. So in all of them, whenever you've got a bradycardia, you can always start with atropine. There's no problem. The problem is that if you've got a wide complex, the chances of it helping are much less than in a wide complex tachycardia. In a wide complex tachycardia, you can start with adrenaline first. It doesn't mean it will work, but your chances are higher. And then if it doesn't work, then you've got to go to pacing and external pacing and things like that I had shown you last week as well. Right. So I think that's the end of it. I'm not sure if you guys have any questions or anything. I think I might have some questions for you all as well.
So,
yeah.
Christian.
Yeah.
Then when it's an unstable patient, you say pacing, right? So
yeah.
Is there anything you can do in the emergency room?
No. So no, I just because I've got my headphones on. So one of the doctors is asking if we need to do pacing. Is there anything in the emergency room? And the answer is no. We don't have any. So it's nice to know. But actually, if it's really an emergency, what we do is that we rush to ICU. We can get pacing pads from them because they do keep quite a few. And those pacing pads are compatible with ours. But luckily, we don't have too many of these per year who are so unstable that they need immediate pacing. The majority of them that I've had over the last little while, they have responded to the adrenaline infusion. And then as we've had a chance to get our pacing pad, so we've got about like 30 minutes to 40 minutes to arrange everything. But if you need somebody who needs pacing now or they're going to go, then you just run straight to ICU. They'll give you a bit of uphill. They will fight with you. They'll want to know if you know how to do it. Why do you want to do it? Have you been cleared by the physician? And then basically, then you call me and I speak to them, and that's about it, right? And you, of course, you get the physician involved immediately, so that the physician knows that you are running to ICU to get the pads, so that they also know that if ICU calls them, they can also correlate the story. All right. So what I'm going to do now is, yeah, you guys can start answering as well. It's no problem. And I'm going to go through the questions with the guys here, just so that they've got an idea of what's going on. So it's just a couple of true and false questions. Like I say, just to make our CPD look a bit more, how do I put it? As though we're actually doing CPD. So certificates are worth something at least, all right? So the first question, in Mobitz Type 1, the PR interval gradually elongates until a beat is dropped. Is that true or false? True, very good. In Mobitz Type 2, the PR interval remains normal until a beat is dropped. True, very good. Type 1 generally has narrow QRS complexes. True. An unstable bradycardia with a wide QRS complex should be given a trial of atropine as it will usually work. False, that's true. It's unlikely to work. Okay, so adrenaline for bradycardia is run at 5 mils per hour by mixing how many amps in 200 mils of crystalloid? 1 amp, 2 amp, 3 amps, 4 amps, 8 amps, 1 amp. Very good. Okay, so thank you to the person who answered as well. On that, I think we'll just stop it. Oh, thank you. 4 people have answered now. All right, so let's go back and see. So an unstable bradycardia. Why we say we're just saying it will. The only reason why we called it false for this person is because it usually won't work for a wide QRS complex. So that's why we said it's false. But okay, everybody's actually done quite well, so not to worry. That's quite good. All right, excellent. So we'll stop it in a little while. So I don't know if you guys have any questions in the meantime, or anything I want to ask, or anything I want to. I know it's a bit of we're starting to get into the slightly more difficult topics when it comes to ECG. It's no longer just MIs, not MIs, because MIs and not MIs are actually a small part of actually ECG reading. I mean, if you look at our Mobitz Type 2 patient, there's very little to indicate ischemia. She could well be severely hypokalemic or even severely hyperkalemic, hypoxic. There's so many things that could be causing it. So we need to know more or less what's going on. All right.
Doc. Yeah. Sorry. I'm assuming you would have obviously still done TROPS and stuff in that first patient because of the ST and whatnot. And then how likely is it that ischemia was involved there?
You can just speak up a little bit. I'm just having a bit of trouble hearing you.
Sorry, I said how likely was it that ischemia was involved there?
Okay, let me go back to it and then we can have a look and see. All right. Let me just put that off. All right. 1 second. So let's just get back to that. Okay, so you're talking about here. You want to know the likelihood of ischemia. Listen, considering it's just a few ST depressions, listen, there is a chance of ischemia, but I would be surprised if this actually ended up being ischemic, okay? Or acutely ischemic, let's put it that way. I would rather look for one of the other causes, to be dead honest. I'd be a bit surprised. I'd be more convinced in this one if there was ischemia based purely on this V1 and V2 Q waves and the fact that the bundle branch block, we don't know whether it's new or old. So that would be more likely. But the truth is that you can't exclude any of the causes, all right? So you have to go and look at all the possible causes. Now, in our case, that's quite easy. It's easy to see if your patient is cold, all right? it's easy to get a history of toxins and trauma. So the main thing, and hypoxia will show up immediately on your SATs. So the main thing is acidosis and hyperkalemia. So in other words, if you are stuck, you've got to look at your ABG. Now I know somebody's going to ask me again, what if we don't have an ABG? Well, then it doesn't really make much of a difference. You send off an urgent potassium and an urgent bicarb, and you can try and work it out from there as well. You can even take lactate levels, frozen lactate, and that can also kind of show you what's going on. Okay. So I hope everybody's okay with that. I know sometimes my own coffee doesn't kick in until about 9:15. So I know sometimes it's a lot to take in at this time of the morning. That's why we share the recording, so that if you forget something or you want to revise, just go back, have a look at it. And you'll actually see these are quite easy to identify after a little while. They're not difficult things to identify. Okay, so any questions from this side? You guys are here. Any questions from anybody on on Zoom?
No, thanks, Doc.
Everybody okay? All right. The reason why I say, unfortunately, I've got to rush off for a meeting now. That's why I made sure I started on time. So listen, guys, I hope you all enjoyed it. I hope it was okay. And yeah, next week we're going to have another quite interesting one. So I hope you guys will come for that as well. Okay. All right. Keep well, everybody. Enjoy the day. Bye.